So we're joined by Dr. John Gibbs, retired paediatrician from the Countess of Chester Hospital, one of the consultants who was working on the ward at the time when Lucy Letby was attacking patients and desperately tried to do something about it.
Yeah, we're really pleased that Dr. Gibbs is here today to talk to us. It's fascinating to have someone that was so close to what was going on to chat to, so thanks so much for coming in.
Thank you. Hello.
Can I ask you first, John, any reaction to the verdicts? We're talking to you in the hours after the verdicts because we wanted to wait and talk to you after that to see what your reaction would be. I suppose for some of the families and for many families it's bittersweet, as the police said, because there's some level of justice, but it also makes it true.
Yes. Well, very much mixed emotions. Some relief that eventually, after a very long trial, the jury have come to conclusions, and also that in most cases they managed to come to a conclusion on most of the babies. The truth is now out. The jury have determined the truth, having listened and spent a lot of time contemplating the huge amount of evidence that they've heard over 9 months, and also a sort of grim satisfaction that the serious suspicions that we paediatricians had about what Lucy Letby we felt might be or probably was doing on the unit have now been confirmed. But of course it's devastating for the families. It's probably particularly difficult though for the families where the jury decided, quite understandably, given the complex nature of the cases, that for a few of the babies, I think 4, they could not come to a definite verdict on them.
Still no answers for those babies. Can we go back to June 2015? Between June 2015 and July 2015, there were 3 deaths. Can you just give us some sense of how that is an unusually high number?
Well, on a neonatal unit like ours in a district general hospital, and we have about 3,000 deliveries a year, 300 to 400 patients get admitted to the neonatal unit, some just briefly, some stay many weeks on the unit. We would normally expect anywhere between 0 to 6 deaths, but usually 2 to 4 deaths a year. To have 3 deaths within just over a month is unusual. That's roughly what we'd expect in a year.
Yes.
And we did think, is there an underlying cause? And at that time, it was something like, is there a strange infection in the unit? But those babies didn't all have an infection associated with their deaths, and certainly didn't have the same infection. If they did, then you'd be wondering, is there some contamination somewhere in the unit? You do worry when you get a little flurry of deaths, but as long as it doesn't continue, that might still be normal. It's because it continued over the year that we became very worried.
But that's why Stephen Breary decided, or kept pushing and thinking, oh, well, this needs looking at. I think he asked Darian Powell, the manager of the neonatal unit, to look at the staffing at that stage, and that's when the first association with Letby was first flagged, I suppose, but not really taken seriously at that point.
No, I think it was noted at that time that Lucy Letby had been involved with all of those deaths. Generally, when we're reviewing deaths of patients in the hospital, and in particular, in this case, neonates on the neonatal unit, we're not really looking at staffing levels because we don't expect a member of staff to be doing anything unusual. And I think it was the various people, the different consultants, and it was different consultants for those early babies who were called in or around at the time the babies collapsed and tried to resuscitate them unsuccessfully for the babies who died, who noticed that Lucy Letby was there, and then someone else noticed Lucy Letby's there, and then another consultant noticed Lucy Letby's there. We do talk to each other because when a baby dies, we review those deaths. We want to know, is there anything we could have done differently? And we're thinking about ordinary clinical care. Did we follow guidelines properly? Did we diagnose everything that was wrong with the baby? And it was through that it was noticed that Lucy Letby was there each time.
That didn't prompt anything else, I'm assuming, at that point.
No, and my feeling when I realised Lucy Letby had been involved in all this death, it was just very bad luck for her and how unfortunate for her. And understandably at that stage, I think the senior nurses on the unit were very defensive of her. She'd been very unlucky, and it's stressful to be, unfortunately involved in several deaths close together.
So then what? It then, as you said, looking at the raw data, the cold raw data, those 3 deaths in a short space of time could have been your annual number, because that would have tallied with what had gone before.
Yes.
But as you said, if it stops there, we're fine.
But in addition to it being unusual that there were 3 deaths fairly close together. There were some unusual features associated with those deaths. Again, that in itself didn't raise significant concerns, just a bit of concern. It was when the deaths and collapses continued, and most of them were associated with some unusual features, that it raised great concern.
Just remind us what those unusual features of the first 3 were.
Unusual rashes, and also unusual responses to resuscitation.
So they weren't responding in the normal way, or they were responding later?
They weren't responding as you'd expect, really, and it varied in different patients. And some of those responses to resuscitation that were unusual could be that there was no response at all, whereas you expect to get some sort of response, even if in the end it's not successful resuscitation. Or for some babies, they responded unusually well. They seemed to collapse catastrophically, have a heart-lung collapse, so a cardiorespiratory arrest, and then seem to recover as though nothing had happened and be temporarily almost back to normal. Now, in retrospect, and I didn't suspect this in the babies I was involved with, I don't think my colleagues did, if there's something like a large air bubble travelling through the circulation blocking the heart, then the baby will collapse catastrophically and could die. With all the resuscitation attempts, you can disperse that air and it pops out of the heart and the baby suddenly recovers. But we didn't realise that was happening. All we knew is these babies were responding in an unusual way, some not responding at all, and some, strangely, responding far too well.
It's the first time I've heard that. So the resuscitation attempts could almost pop the air bubble.
I agree that that didn't really come out, but there was talk in the trial of the kind of CPR efforts that went on for a long time and eventually worked, and nobody could work out why. I think Baby M was one of those.
It's not unusual not to respond fully to resuscitation because, sadly, at any age, patients who deteriorate, particularly if they've got usual medical conditions that are overwhelming their body, when they deteriorate and have a cardiac and respiratory arrest, a severe collapse, it's not always possible at all to save those patients. But it's just that for babies that had appeared to be behaving normally, the observations were satisfactory, to suddenly collapse and then you can get no response and the resuscitation is unsuccessful, that's unusual. So it's a combination, not just that the resuscitation was unsuccessful, there was no indication why the baby collapsed in the first place.
You can't always predict, and
you don't always have the answers, and very frustratingly for families of a patient who's collapsed and sadly sometimes died, it's not always possible to determine exactly why some patients have collapsed. So we don't have all the answers all the time in medicine, but it was the sort of developing pattern of repeatedly not being able to explain the deaths or having unexpected collapses.
Because then we heard, obviously, after those 3 deaths, that another baby died in August and then another baby died in October. So you're kind of looking at 5 deaths in a fairly short space of time. And I think Dr. Breary emailed managers at that point and said, I'm concerned about this spike in deaths, and the association with Letby was noted again. And I think at that point we heard that Alison Kelly, the nursing director, said, we'll see. Let's see what happens.
Yes.
And nothing was done again. And then you fast forward again to February. By this point, a specialist from the Women's Hospital had been asked to have a look at the run of deaths. And although he couldn't find a cause, again, the association with Letby was flagged. And that's, I think, when it became a bit more serious. Is that correct? Is that a right reading of it from February?
Yes. I think by October, suspicions were just beginning that could it be anything to do with Lucy Letby? Because as we said before, it was noted for those early deaths around June and July that Lucy Letby had been involved at the time of their deaths. But that was felt to be just a coincidence and bad luck for, at that time, poor Lucy Letby. When she continued to be associated with some deaths and collapses, and those deaths and collapses in various ways seemed unusual, or not always, but sometimes completely unexpected, that then started to raise dark suspicions that could Lucy Letby be doing something. But again, no one knew what it was she was doing. No one saw her do anything to harm a patient. But it was by February time, when these collapses and deaths were continuing, that a review of all the deaths since the previous June was undertaken. As you say, an experienced neonatologist, consultant in newborn care, he came to the County Chester Hospital to review the deaths, and he'd looked through the paperwork and the records beforehand. And it was noted that some of these deaths seemed unusual, and that was in the opinion of this outside neonatologist.
But he also highlighted her presence, didn't he?
That Lucy Letby had been involved in all of them, yes.
You talked about dark suspicions by October 2015.
Well, so they began to emerge then.
How does that manifest as a group of experienced consultants? What are you saying to each other?
Well, I say we're only beginning to wonder whether there might be some worrying association, not just that Lucy Letby just happened to be there, but why was she there each time these unusual collapses were happening? The main concern at that stage was that we were having an increasing number of deaths and collapses, and we were still looking and searching for normal, ordinary clinical reasons for that.
Yeah.
And we kept asking ourselves, we didn't have to be asked this repeatedly by the defence barrister during the trial, we were asking ourselves, are we doing something wrong? Are our procedures and practices failing in some way? Why is this happening?
But there was nothing.
There was nothing that explained the deaths and collapses. Clinical care doesn't always proceed perfectly all the time for every patient. And in reviewing the deaths and collapses, it was noted that on occasion, antibiotics hadn't been given quickly enough. On occasion, infection hadn't been diagnosed early enough. There are certain medicines that premature babies need to help their lungs when they're very stiff. And on occasion, not every time, just in the odd patient, it wasn't given early enough. So there were all ways that we could have improved our practice. We didn't think any of those ones I've mentioned actually caused the death, but they may have contributed to it.
Okay. At that point then, in sort of, from October to sort of February, what was the atmosphere like on your unit? How was it working there?
It was a little tense, but every neonatal unit is busy. There's a lot going on. There's a lot of babies who are quite vulnerable with very special needs, and most of your effort and thoughts are directed to doing the best you can for the babies. I don't think most of us, or I wasn't at that time, worrying about Lucy Letby most of the time.
Yeah.
There was dark thoughts at the back of your mind. And then, sadly, we were hoping that because these deaths were being reviewed in the risk management review structure, that these concerns would be addressed through that means.
And so do you think then that, the very nature, like you said, of a neonatal unit being busy, that helped her do what she did because people were, maybe distracted?
Yes, I think that's quite true. And that Lucy Letby herself didn't behave abnormally as far as I could see at all on the unit, and she was quite quiet and she seemed conscientious, and no one saw her do anything to harm a patient.
And that helped her operate in plain sight, like we've talked about, and go under the radar,
Yeah.
essentially.
Yes.
When is the first point at which managers, you feel, should have acted?
I know that it's been pointed out that the association with Lucy Letby was noted after the first 3 deaths, so by July 2015. I don't think any of us, or certainly speaking for myself, really thought that anything suspicious was happening at that time. It's different in retrospect when you've looked at what's happened over the year, when you look back at those deaths and discuss them in court. Yes, we were very worried about them and we were concerned about Lucy Letby's association with them. But that concern was because what had happened, over the subsequent months, not at that time.
Yes.
The managers couldn't have done anything at that time. It would have been inappropriate for them to have taken further action at that time. I feel probably the same applies to around about October 2015 as well. We were not saying to managers, we think someone might be murdering babies on the unit or trying to murder them in October. By February, when an external experienced senior paediatrician, neonatologist, had come to help review the deaths with Stephen Breary and some of the nurses and the risk management team, and concerns were highlighted at that stage